Okay, if you can just bear with me, we're just waiting for YouTube and Zoom to get together and start sorting it. Okay, if you can just bear with me, we're just waiting. Right, okay, so we're now live on YouTube. Right, hello, my name is Marcus Green. I'm the Chief Executive of Action on Preeclampsia. We're the UK charity that supports women with preeclampsia or who have had the experience or are just concerned about it. Tonight, we're going to have a conversation with two of the leading experts in the UK about preeclampsia. Professor Andrew Shennan, who is Chair of Trustees of APEC, and Professor Jenny Myers, who is the Research Director of APEC. So, Andy, Jenny, absolutely lovely to see you. Thanks very much for giving up your time today. Andy, we'll start with you if I may, and then we'll go to Jenny with the same question. So, what got you involved in APEC in the first place, Andy?
Well, I've been a fan of APEC many years, actually, since I was a junior doctor. My boss at the time was on the board, and he basically asked if I would get involved. I started giving lectures to midwives and other health professionals. I had an interest in measuring blood pressure. And essentially, I kind of learnt very quickly that it was a very worthwhile venture, and it was really tackling the sort of individuals who really make a difference on the shop floor, and particularly the women who suffer from the condition. That's what APEC's about. So I've been a huge fan ever since. Completely delighted to end up supporting it now as chairman.
Wonderful, thank you, Andy. And Jenny, how did you get involved?
Yeah, similarly, I was invited down to an APEC meeting when I was a junior PhD student, and when I was first starting my research in preeclampsia, and I was invited down to a meeting, and I met all these people at that meeting that I'd been reading their research, and like Andy, and real privilege to be involved and to meet the people both really driving the research and really driving the improvements around preeclampsia, but also meeting and being able to be part of the charity in terms of interacting with people who've lived experience of preeclampsia and really being able to interact in that way as well. So really great experiences. Contributing to the study days has been really fantastic, and the expert meetings, and now as a trustee and research director, really being able to drive and influence how the charity does things and what the charity is doing. So it's a real privilege to be part of such a great organisation.
Thanks very much, Jenny. The purpose of this evening is we're coinciding with World Preeclampsia Day here, and we're getting right back to basics and looking at some of the things that what preeclampsia is about, some of the things that people may have heard about, particularly around placental growth factor testing, PLGF testing, and home blood pressure monitoring. But Jenny, let's get right back to basics. What is preeclampsia?
Well, preeclampsia is a condition that is unique to pregnancy, and it's a condition that causes high blood pressure mainly, and a number of other signs and symptoms which can affect the whole body during pregnancy. Usually happens in the second half of pregnancy, and it's a condition that is caused principally by the placenta. So if the placenta is not developed properly or is damaged during the pregnancy, then the placenta sends signals into the mum's body that causes these changes: the high blood pressure, protein leaking into the urine, swelling, and other changes in blood tests, which can often be associated with severe preeclampsia.
Okay, that's great. So Andy, what actually? Let's talk about what causes this. What are the causes of preeclampsia?
Well, I mean, the simple answer to that, Marcus, is pregnancy, and we don't fully understand the mechanism. And part of the problem is that because we don't fully understand it, anyone can get it who's pregnant, and we have to watch every single pregnant woman carefully, regardless of who they are. However, we have clues as to who might be more susceptible to it, who's more likely to get it. And as Jenny says, it's probably related to the placenta. The placenta comes from both the mother and the father, and therefore has some foreign materials in it. And it's a combination of the reaction that the mother has to this foreign. The paradox is that you need to be used to your partner, and the more used to them you are, the more babies you have, the less likely you are to get preeclampsia. So we have clues as to who's more likely. So for example, your very first pregnancy, you're more likely to get it. And then, that's probably related to this interaction, immunology of it. But also there are genetic things. Some people are just more likely to get it. And if your mother's had it, you're more likely to get it, for example. And then you might be more susceptible to it. So there are people who have certain conditions that make you're more likely to manifest it. So if you're overweight, if you're older, if you already have underlying high blood pressure, or other medical conditions, or things like multiple pregnancies where there's more placenta around. These are all kind of factors that we know we have to be a little bit more tuned into. Could that be the case? And even sort of odd things like if you have a donor egg through IVF, that means there's more foreign material and you have a higher risk of preeclampsia. So all these observations give us clues who's more likely to get it, and then it helps us manage it. But going back to what I said, first of all, we shouldn't lose sight that absolutely anybody, even with no risk factors at all, might get it. And that's why, we have to have this very careful management and people being aware of it and the symptoms and how to manage it.
Okay, so Jenny, what are the signs and symptoms? What should pregnant people and their partners and people around them be looking out for?
So most women who develop preeclampsia don't actually have much in the way of symptoms often. And so the most important thing to be doing as a pregnant woman is making sure that you're having your regular antenatal checks. And those antenatal checks are really designed to check and to see if you are developing any signs or symptoms of preeclampsia at each one of those checks. So the first thing to say is that those routine antenatal checks are there for that purpose, to screen for preeclampsia, and really important that those are done. The signs of preeclampsia are usually high blood pressure and protein in the urine. They're the signs that we most commonly see in women during that antenatal check that would alert us to the possibility that this is preeclampsia. There are other symptoms that we can develop, so things like headaches, visual disturbances, pain in the upper abdomen, new nausea and vomiting, very severe or quite sudden onset swelling. Those are symptoms that can happen. And if pregnant women develop any of those, and in between a routine antenatal check, they should always seek medical advice.
Okay, that's great. Andy, I want to take something that Jenny's just said and something you said earlier. And you said any pregnant woman can get this. And Jenny mentioned the antenatal appointments. How important is it that women should be attending these? I mean, we're living in the era of COVID. People are concerned about that sort of thing. What advice would you give to women today?
Well, absolutely critical, Marcus, that people don't miss their appointments. And one of the principal aims of those appointments actually is to check the blood pressure and to look for the possibility of preeclampsia. And the reason why it's so important is that if you detect it and you know it's there, you can do so much to prevent problems. You save babies, save mothers, and manage it. It's very easy to manage if you know it's there, but if you don't know it's there, and as Jenny says, you may have no symptoms at all, it can be devastating and life-threatening. So absolutely critical to have your blood pressure regularly checked throughout pregnancy. And if you go and attend an antenatal appointment and your blood pressure is not taken and your urine is not dipsticked, that is wrong, and we advocate that everyone should at least ask for that if it isn't offered. If this is done well, and we know it is done well in certain places, particularly in the UK, we can make a big difference. And if you go to countries around the world where it's not done, the differences in outcome are absolutely staggering. So absolutely critical to have regular checks. particularly because you can't rely on these symptoms that Jenny mentioned. You know, they do happen in some cases, and that's a flag to go and get checked sooner. But even if you're feeling completely well and have no risk factors at all, you can still have bad preeclampsia without knowing about it, and you must get your blood pressure checked regularly as recommended.
That's great, thank you. Now, Jenny, you take you're aware of the calls that we get through on our helpline. You follow up with quite a lot of our patients, which is absolutely fantastic. So thank you for that. But one of the questions that we get, particularly from women who are thinking about getting pregnant in the next, say, 18 months, couple of years, are the things they can do to prevent it, particularly when say their mum's had preeclampsia before them, or there's a family history. What steps can women do during that time when they're planning to get pregnant?
Yeah, so there are a few things that women can do that will help. And so those are kind of quite boring things and things that we should all be doing. So having a healthy diet and lifestyle is definitely an important thing. Being a healthy weight in the run up to a pregnancy is definitely helps. Overweight women are at slightly higher risk of developing preeclampsia. There's no harm, especially if you've got a family history or any of the risk factors for preeclampsia that Andy mentioned earlier. There's no harm at all in getting your blood pressure checked before you have a pregnancy, just so that you know that your blood pressure going into pregnancy is normal. That's a good thing to do. And we don't have any specific additional medications or supplements or anything you should be taking in the lead up to pregnancy, apart from your routine folic acid that you should be taking in the run up to a pregnancy. But once you are pregnant, we would recommend, if you've got any risk factors, the NICE guidelines would recommend that you have aspirin, and you should usually start that from around 8 to 12 weeks. And that reduces the risk of developing preeclampsia in your current pregnancy. And the good thing about aspirin is that we know it's a safe intervention. We know it's safe for you and for the baby. And it's usually pretty easy to take. Most women don't get any major side effects from it. And if you're high risk or you've got any risk factors for developing preeclampsia, then aspirin will reduce your risk. So it's well worth considering taking aspirin from the early part of your pregnancy.
Okay, and who should be making that decision, or who should be advising you to take aspirin?
Yeah, so when you have your first antenatal visit with your midwife, which usually happens around 8 to 9 weeks, your midwife will go through all of your history, your family history, and assess your risk factors. And there's a standard risk assessment tool that we use for preeclampsia. And if you have any of those risk factors, then we would recommend that you have aspirin, and then your midwife will advise you on how and where to get hold of your aspirin prescription. Okay,
thank you. Now, Andy, Jenny just mentioned about measuring your blood pressure at home and doing that in the run-up to getting pregnant. There's been a lot of talk about this recently, particularly in the preeclampsia world, and I know that we get women phoning us up on the helpline about blood pressure monitoring. What advice would you give on that?
First of all, I mean, as we've already said, having your blood pressure checked on regular occasions is obviously highly recommended and a very critical part of being safe during your antenatal care. So if as an alternative to having it done at hospital or at a clinic, at a GP surgery, it's perfectly reasonable to have it done for ease and convenience at home. Now, obviously, it shouldn't be in substitute for the other checks that are needed during antenatal care. You know, we do much more than just measure blood pressure. We also check on the baby and, a number of other things. But particularly if you're at risk and you need more frequent monitoring of your blood pressure, it may well be in tandem and under supervision of a midwife or doctor. You could very easily have a home monitor, which allows you to get extra checks as long as you know what is abnormal and what to do about it. And that can only be a good thing in terms of diagnosing the condition earlier. The important thing about home monitoring is to do it under supervision. Don't do it instead of normal antenatal care, and use equipment that is appropriate for pregnancy, because not all these blood pressure devices are good for pregnancy. They may be good for non-pregnant people, the ones you buy over the counter in the chemist. And it's worth just checking with your clinical care team that the monitors you're using are appropriate for this type of assessment. And I guess, you know, we just come out of COVID, of course, and there was huge issues with accessing healthcare. And much better than just not seeing people is to have a home blood pressure monitor. So sometimes it's a necessary alternative, even it may not be optimal.
Absolutely, and I'm going to throw in a free advert here for APEC and for the blood pressure monitor that you developed, the Cradle device, which is available on the APEC website, apec.org.uk. It's calibrated for use in pregnancy. It's an absolutely smashing device, and we highly recommend it. So if you want to get one, have a look on our website. It's there. So that's home blood pressure monitoring, important. And one thing that I always say is, if you're measuring your own blood pressure, get your partner to measure theirs, because the guys don't tend to check theirs anywhere near as frequently. So it's always a good idea, I think, in any way, or for general health. Now, one of the other things that's in the news at the moment, Jenny, and we've seen a lot of this over the last 6-9 months, maybe the last couple of years, really, and a big change is PLGF testing. And there's a lot of confusion about PLGF testing, and this really is the nub of what we need to discuss today. So, Jenny, can you take us through the history of what we know about PLGF testing, why it's important, and what it is, please?
Yeah, absolutely. So, I mean, PLGF testing is a really exciting development in our management of preeclampsia, and it really has, for me, changed the way that we do things in terms of how we can risk assess women and give women a reassurance in lots of situations, to tell them they're not getting preeclampsia, and also to identify the women that are developing preeclampsia and therefore need really careful monitoring. So there are two molecules that are produced by the placenta. One's called, we'll call it solublit for short, FLT1. One's called placental growth factor, which is nicknamed PLGF. And those two molecules are produced by the placenta, and you can measure them in the maternal in a maternal blood sample. And research over the last probably 10 to 15 years, much of which has been supported by APEC, has really shown that testing these molecules in the maternal blood test identifies that placental damage. So that we were talking before about the placenta kind of causing, or you have to have a placenta to have preeclampsia, and when these molecules are dysregulated in the maternal blood, that's a sign that the placenta is contributing to the changes that we're seeing in the mum. So if you imagine a scenario where a mum has developed a new blood pressure reading of, say, 140/90 or 145/95, about 1 in 10 women during their pregnancy will have a blood pressure over that 140/90 threshold. And our job as doctors and midwives is to try and understand what is the risk to that woman who's got that blood pressure reading. Or it might be that we found some protein in the urine. Similarly, is that a sign that preeclampsia is developing? And so previously what would happen is that that woman would need to go to the hospital, have some more tests, be checked out, maybe be admitted to the hospital to have regular blood pressure monitoring, maybe have some more tests the following day. Now, as part of that assessment, and it is part of that assessment, we don't do it instead of that assessment, but as part of that assessment, we can do this new blood test. And so within a few hours, we're able to say to the woman, yep, it looks like you are developing preeclampsia, so perhaps we do need to admit you to hospital. We need to do some close monitoring. Or more commonly, actually, 2/3 of the time, you're not developing preeclampsia. And actually, this was a one-off borderline blood pressure, or perhaps your blood pressure's up for another reason. Perhaps you had higher blood pressure to start with during this pregnancy. And so at the moment, you're not developing preeclampsia, and the blood test is good for a couple of weeks. So it tells us with really good certainty that lady is not developing preeclampsia, and therefore doesn't need any additional monitoring in the next 2 to 4 weeks. So it's really changed our ability to give women certainty about what's going on, and to be able to have proper conversations about what the risks are, and what their next, their ongoing care needs to look like. And it isn't always good news, and sometimes it does confirm preeclampsia, and often actually it confirms preeclampsia before we would have made the diagnosis based just on the other clinical signs and symptoms. But it allows us to start preparing women and their families for what's ahead. And it also allows us to get the right surveillance in place. So that might be inpatient monitoring, or it might be very close outpatient monitoring. It means we can get things like steroids in a timely way if a baby needs to be born prematurely. And as Andy was saying before, it means that we can prevent all of the really serious complications happening, certainly for the mother, because we know the condition's developing, and we can therefore watch and act before the serious complications occur.
Yeah, it's really helpful. What we haven't touched on there is the timing of the PLGF test. Now, Andy, perhaps you can help on this one. We had a woman phone up the helpline not so long ago who had preeclampsia in her first pregnancy and was planning on having a second pregnancy. And she asked two questions. One, do I get the PLGF test before I get pregnant, and can I get it privately? So can you help with those problems?
Well, first of all, just to answer those specific questions, the test is only valuable while you're pregnant, because what it's actually doing, as Jenny says, it's measuring how well the placenta is working. So it doesn't tell you how you are as an individual, it tells you how that pregnancy is performing and whether preeclampsia is coming or has arrived, as it were. I'm not aware that anyone is doing it privately. The thing about preeclampsia is it's potentially a very serious condition, even if you feel well. So private care, it doesn't lend itself to good private care. Private care is usually about experience and individuals kind of looking after you over a long period of time. If you have a serious condition, you need people looking after you 24/7 and looking after your baby and so on and so forth. So the NHS is the perfect kind of tool for looking after a serious condition like preeclampsia. And I wouldn't say, go looking privately if you think you've got preeclampsia. That said, private people can use these tests, and I'm sure in time that they'll realize how good they are, and I suspect they'll be adopted. When to do it? Actually, you can do it any time in pregnancy, even from the beginning of pregnancy. Some people have advocated using it to work out who should get aspirin, for example. That's something that we haven't yet adopted in the UK because it's relatively expensive, and there are simpler ways to direct aspirin. However, the real advantage, and I think Jenny's alluded to this, is that when people turn up with suspected preeclampsia, because that we genuinely don't have good enough tools to tell us who is genuinely going to be very seriously ill and who's absolutely fine and can be safely sent home and not worried about. And this test has been a real advance in giving us a simple result that effectively tells you whether you're falling into one or two of those camps. And it makes a huge difference to the individual in terms of what happens. So the real advantage of the test is to use it in a situation where you have a woman turns up because she's got slightly high blood pressure, or because she's got a headache or a small baby or something like that, which thinks this could be preeclampsia, then the test is incredibly valuable. Now, if you'd taken the test in that woman months earlier, it would have told you it was coming. But it's a bit more confusing then, because you get told the disease is coming, but it might be a long time from now. Whereas if you've turned up with symptoms, we know it's got a really good relationship to what's going to happen to you. So you should only have this test under supervision. Fortunately, at the moment, the vast majority of units in England have adopted this, along with the UK's initiative to introduce it. So we think it's about 85% of them. And we are hoping that in the not too distant future, it's going to be 100%. So you should be able to access it, if not now, in the near future. Okay,
so taking what both of you are saying, and trying to understand this a little bit more, you get presented with a patient who's got signs and symptoms, perhaps, or you've got some suspicion at some point in the pregnancy, and then the PLGF test is another tool in your armory to help you decide whether it's a good idea to place a woman on normal care, where she's back to the midwife, or whether we need to look very much more closely with increased monitoring at the minimum, and possibly even having to bring the woman into hospital. Have I got that right then?
Yeah, absolutely. And we would use it, that the test is at its most useful, as Andy says, for managing women who are developing the disease. So there has to be a degree of suspicion that the disease is developing. And so when the research studies have shown that the test is effective and makes a difference, is when we do it in women who have presented with a symptom or sign that could be preeclampsia, and that is most commonly a change in the blood pressure, but it could be those other symptoms that we talked about earlier, or it could be protein appearing in the urine, and so all of those things could be possible signs of preeclampsia developing. And if we do the test at that time, and the test is currently recommended to be done between 20 weeks and 36 weeks and 6 days, so less than 37 weeks. So it's not a test that we would recommend using after 37-week gestation, which is when a lot of women do develop preeclampsia, and it still can be a major problem if preeclampsia develops after 37 weeks. But we tend to manage it slightly differently after 37 weeks, because we would usually be thinking, if we thought preeclampsia was developing at that stage, we would usually be thinking about offering delivery of the baby. But before 37 weeks, the test is very, very useful. Where obviously we don't want to be delivering babies before 37 weeks unnecessarily, and that's where the test is really useful at working out who needs, as you say, that much more careful surveillance, and who could return to normal care.
Okay, that's great. So thanks for that. I think we've probably covered off PLGF testing in England. And Andy, as you say, it's available in 85% of or available to around 85% of women at the moment. And that's up from 0% a couple of years ago, and we're pushing towards 100. So that is fantastic in England. Do you know what the situation is across the rest of the UK, and how are we comparing with the rest of the world?
Do you want me to say that? So, well, we are trying with APEC's help, aren't we, Marcus? We're trying, and I think there are real positive vibes in Wales, certainly, and that adoption is coming in Wales. And I think there is a lot of shouting happening in Scotland, and so there is movement, I think, within the Scottish Health Service as well. I know that I'm doing a talk in Dublin in a couple of weeks, and I know that in Ireland there are also moves to be adopting as well. So I think across the UK, I think we really have been leading the way in terms of demonstrating that the test is useful with really rigorous research. That research has been reviewed by a NICE diagnostic assessment panel, who reviewed the evidence a few years ago, made the early recommendations, and then have re-reviewed the evidence and made stronger recommendations recently. In terms of across the world at the moment, very patchy in terms of what's available. So there are some countries in Europe. So for example, in Germany, this test has been available in some units in Germany for quite a while. But in other parts of Europe, not so much. So, and then across beyond that, not yet available in the US, although people are pushing hard in the US to have the test adopted. And I think across other parts of the world, we've still got a big challenge on our hands to make this test available to the women whose antenatal care would be, really revolutionised if we could make this test accessible. And Andy would be able to speak to that. If we could make this test accessible, in healthcare settings where antenatal care is not as well developed as it is in the UK.
Yeah, I mean, the paradox here, Marcus, is the test is very, very good, but a test is not a treatment, and it doesn't make you better. So what's really important is what you do with that knowledge in terms of making a difference. And of course, what you might do in a low-income setting where things are very challenging and there's no facilities and no monitoring of the baby would be very different to what it is here in the UK. However, that said, because outcomes are so devastating around the world from preeclampsia, and that's a real kind of reflection on how successful we've been in the UK by this monitoring and prompt action. We save a lot of lives because we haven't cured the disease, we just manage it better. If you go across, to West Africa, you're literally thousands of times more likely to die from preeclampsia, which really illustrates how serious a disease it is and how we mustn't forget that. And using something like a PLGF test in that environment would be very exciting. We are certainly doing research in finding ways of getting cheap, finger prick type tests into that environment. And actually there has been success in places like Mozambique and South Africa in using the test. But obviously the finances and the commercial input is very interesting and an important part of this. I gave a lecture in Poland and Bulgaria, Romania recently, a lot of interest, and a lot of people were obviously using it. So I think people are getting the message, but it's fair to say the UK, I think, has led the world on this, and we should be proud of that and may take advantage of that.
Excellent. Well, I think that probably covers two of the three areas I wanted us to talk about today, which was blood pressure monitoring, PLGF testing. But one of the other areas where we seem to be getting a growing amount of knowledge is that if a woman has had preeclampsia, then they need to keep a closer eye on their health long term than your average woman in the street. So, Jenny, can you fill me in a little bit about where we are, what we know, and what a woman who's had preeclampsia, what messages they need to hear so they can improve their life outwards?
Yeah, so it's a fascinating area, Marcus, and one that's really rapidly evolving. It's been very under-recognised in terms of cardiovascular health and poor cardiovascular health outcomes in women. And I'm sorry to say that most of the research around cardiovascular risk prediction certainly has. Most of those studies have been done in men, and most of the prediction algorithms that we use outside of pregnancy to predict future cardiovascular risk, and I'm talking things like heart attacks and strokes, most of those risk prediction tools have been are designed for men. And we now know, and there's really a rapidly growing body of evidence that shows that the women that have had pregnancy complications, particularly preeclampsia, but actually not just preeclampsia, but particularly preeclampsia, have an increased risk of developing cardiovascular disease in the longer term. Now, I think it's important that we don't, I don't want to terrify everyone, and we're still talking about small risks, absolute risks. The risks of women in their 30s and 40s having serious heart attacks and so on is still very, very low. But the reality is that women who've had preeclampsia are more likely than their next door neighbour who didn't have preeclampsia to have a cardiovascular problem in the 5 or 10 years after their pregnancy. So the question is, what do we do about that, and how can we help women? And so I think the first thing is that knowledge, isn't it? And we're doing a lot of work between us to try and get healthcare professionals and women understanding that preeclampsia and pregnancy complications might be something that we need to be alert to after the pregnancy in terms of watching things like blood pressure, particularly very carefully. And so a really simple message is that if you have had a hypertension problem in pregnancy, if you've had high blood pressure in pregnancy and preeclampsia in pregnancy, we need to be monitoring your blood pressure carefully in the first few weeks after your pregnancy. And then we need to be monitoring your blood pressure going forward. So it doesn't stop when your baby's a year old. And what I say to women is use the birthday of your baby as an anniversary prompt. Have I had my blood pressure checked? My baby's now 1 year old. I need to get my blood pressure checked. And just do that kind of stop gap and get down to the GPs and get an MOT and just get checked out. All of the other things, I'm afraid, that we talked about in terms of preparing for pregnancy all still apply. So, healthy diet, lifestyle, obviously smoking, being fit and active, all of those things help to modify your risk of cardiovascular disease, heart attacks and strokes. So all of those things are really, really important as well. And I'm afraid if you're someone who's developed preeclampsia, usually through absolutely no fault of your own, if you develop preeclampsia, then I'm afraid you need to be extra vigilant in terms of having a healthy diet and lifestyle and you need to be extra vigilant in terms of getting your blood pressure monitored at least once a year.
Marcus, I see this as you can put a positive spin on this. I think Jenny's absolutely right. You don't want to overreact and frighten everyone. However, it's such an opportunity. We think of pregnancy now a bit like a sort of opportunity to reveal problems that you might have in later life, and it includes things like diabetes and also these cardiovascular risks, having heart attacks and strokes. And if you get preeclampsia, first thing to say, it's not your fault. And also the preeclampsia itself may not have been the cause. It may just have revealed that you're that type of person. So don't say, oh, well, I mustn't have any pregnancies because it'll cause me a problem. It's just, in a way, told you that you have this underlying condition, and it allows you to do something about it. So you will see your GP more often as you get older. You will take your blood pressure tablets, and you will stay fit and healthy and nice and slim, because it's just another risk factor and you can counteract it. So a way that here's an opportunity to say, right, this is revealed for my future opportunities to have a better lifestyle and look after myself, because none of us know what's going to take us off in years to come, and you're lucky that you've got something to target to prevent.
Okay, that's great. Thank you both very much for giving up your time. It's been a fascinating session. Really enjoyed it this evening, so much appreciated. I'd just like to finish by saying we've done this for World Pre-eclampsia Day. Pre-eclampsia is a serious condition, as we've heard about this evening. We're pretty good at dealing with it in the UK, but not perfect. But in other parts of the world, it's a very, very serious condition which cannot and should not be ignored. Action on Preeclampsia has been around for the last 30 years. We've been working on a whole host of things to try and put these pieces of the jigsaw together. And I think tonight, in discussing home blood pressure monitoring, PLGF testing, and long-term health complications, we've got three of the pieces of the jigsaw which are really important and really helpful. So Jenny, Andy, thank you very much. Really appreciate your time tonight.
Thank you, Marcus. Thanks, Jenny.
Thank you, Marcus.
Thanks very much. Cheerio. Bye-bye.
Yeah, bye.